Here's Miss Mary again. This is chapter 22, the cardiovascular system, which I love. So get ready. Let's get moving and go through the cardiovascular system. I have included on the very first slide terms that you need to know with the definitions of them. You're welcome. Okay, so what is the heart? The heart's about the size of your fist, and it lies in the thoracic cavity in a smaller cavity called the mediastinum. And the heart kind of tilts to the left. Two-thirds of it are near the body's midline, but the broadest part of the heart, the base, is at the top, and the apex is at the bottom. The point of maximum impulse, that's where you can hear it the best, the strongest beat can be felt or heard, is at the apex. And remember, left mid-clavicular line, down between fifth, sixth, maybe seventh intercostal, depending on the patient and their size. And great vessels enter and leave the heart at the base. The great vessels are the vena cava and the aorta, the biggest vein, the biggest artery. Okay, let's go. So what does the heart do? The heart's a pump. So it pumps blood to the body and the lungs, and it receives blood from the body and the lungs, arteries, veins. It influences blood pressure. And your blood vessels are there for basically for transportation. They're channels where the blood flows through, and they also all lead to smaller arterioles and venules, which are tiny veins and arteries in capillary beds. And that's where gas exchange takes place, wastes, nutrients, all kinds of stuff. So let's take a look. There it is. Okay. There is the outline. There's the heart, kind of sits in the middle of the chest. That's the base. That's the apex. That's the point of maximum impulse. And there you go, the intercostal spaces. Practice finding it yourself on you, okay, so that you get good at it. So now let's talk about how the heart is made, the anatomy of the heart. So the exterior of the heart, you have the pericardium. And the pericardium is a double-walled sac, and it's got two layers inside of it. You don't need to know the names of the layers, but know this. In between those two layers, the fibrous and serous pericardium, there's fluid, right? Serous fluid. And that kind of prevents friction when your heart beats, right? That pericardium expands also. And that fluid's like a lubricant, okay? Teeny tiny amount of fluid. So here we're looking at a cutaway of the layer of the heart. And you can see the endocardium, which is the innermost layer, the myocardium, which is the cardiac muscle, very important. And that's the thickest layer. And then the epicardium, which is the top layer, is all surrounded by this membrane called the pericardium. Okay. And remember, endo means inside. That's how you remember the endocardium is the layer innermost. The myocardium is the middle, the strongest, thickest, and the epi is on the outside, surrounded by the pericardial sac. And then when you look inside the heart, and I know it seems like a lot, but I'm going to try to make it as easy as I can. So inside the heart, you have chambers. The two top chambers are the atria, left atrium, right atrium. The two bottom chambers are the ventricles, left and right ventricle. You have valves. Remember, one-way valves. Everything in your body is South Philly. Blood's going one way. Okay. And when you look at this picture, I just want you to take note. This is your left ventricle, and this is your mitral valve. This is your left atrium. Look how thick the walls of the left ventricle are compared to the walls of the right ventricle. That's because the left ventricle is the queen mother of the four chambers. Remember that. Okay. And here's another view of it, but kind of the same thing. You can see this is the vena cava, superior and inferior. This is your aorta, pulmonary arteries. You don't see the pulmonary veins. You do kind of right there, pulmonary veins. All right. So now let's talk about the valves in the heart, those one-way valves. All they are just kind of things that open, let blood go through, and then shut. Open, shut, open, shut. And you have the pulmonic valve, the aortic valve, the tricuspid, and the mitral, okay? And when we get to the blood flow through the heart, you'll hear me say those valves in the order in which the blood goes through them. Okay. Here's another picture, right? Blood flow through the heart. You're going to like this because you need to get it. okay? And it's not hard. Deoxygenated blood, blood without oxygen, is going through your veins, traveling up, 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 or down, down, down to the heart. And all your veins meet at the superior and inferior vena cava, and that deoxygenated blood goes into your heart, into the right atrium, goes through the tricuspid valve to the right ventricle. The deoxygenated blood leaves the right ventricle through the pulmonary arteries. It's the only time an artery carries blood without oxygen in it, is right here. Pulmonary arteries, there's two on each side, from that right ventricle, pump that deoxygenated blood to the lungs, where the blood drops off carbon dioxide, picks up oxygen, and now has to go through the pulmonary veins. There's two here, into the left atrium, through the mitral valve to the left ventricle, through the aortic valve, through the aorta, and into systemic circulation. Got it? You will, don't worry. It's all going to make sense, okay? But you need to understand the blood flow through the heart. Here is a step-by-step. Deoxygenated blood enters, right? Goes into the right atrium, through the tricuspid valve to the right ventricle. It leaves the right ventricle, lub-dub, through the pulmonary arteries and goes to the lungs, okay? There you go, boom, boom. So there's two on either side to go to each of your lungs, okay? Blood goes there, drops off carbon, picks up oxygen. Now through the pulmonary veins, the blood comes back and enters through the pulmonic valve into the left atrium. And then let's go to the next picture. And then it goes left atrium, mitral valve, left ventricle, and from the left ventricle, whoosh, out through the aortic valve, into the aorta, and into systemic circulation, okay? Very, very important to understand this. This is how it's supposed to work normally. To understand it when it's broken, you need to understand how it's supposed to work when it's healthy, okay? So that's the blood flow through the heart. When the left ventricle fails, the blood backs up, and it's not supposed to do that, where it came from. The blood in the left ventricle came from the left atria, but it came from the lungs, right? So it's going to back up to the lungs. Whereas right-sided failure, okay, the blood in the right side of your heart came from the vena cava, right, which is the body. So it's going to back up to the body. And let me try to make that make sense. Left failure, left is lungs. The symptoms are in the lungs. Left-sided failure, lungs. Shortness of breath, pulmonary edema, coughing, and also, let me add, pink frothy sputum, because that's another symptom. So what's happening is the blood's backing up into the lungs, mixing with fluid, and that is that pink frothy spuid when they cough. We'll get more into heart failure when we get to med surg, but this gives you a basic understanding. Left failure is lungs. Right failure is body, because the blood backs up into the body, okay? I'm going to put here, body. And the symptoms of this are edema, they'll have swollen feet and legs, abdominal ascites, swollen abdomen, jugular vein distension, right? Jugular vein, and hepatosplenomegaly, which is an enlarged liver and spleen due to fluid overload. Okay, so left is lungs, right is body when we're talking about heart failure. Left is lungs, right is body. Okay, good. Now, the blood vessels of the heart, the coronary arteries. Now we're talking about this other system. That was the system of the blood flow through the heart and body. Now we're talking about the coronary arteries, arteries that feed oxygenated blood to the heart muscle, the myocardium. Let's see. There you go. Okay. The aorta, there's a little branch off of it that feeds these arteries that feed the myocardium. This is the right coronary artery, RCA. And this is the left coronary artery and the left anterior descending. The widowmaker. Why? Because if this bad boy gets blocked, it cuts off blood flow to the myocardium over the left ventricle, which is the queen mother. And then you're going to have an MI, a heart attack. Okay? There's another good picture. This really breaks down all the different arteries and veins. Okay. There we go. Now let's talk about the third system, which is the electrical system, cardiac conduction. Just like when you start your car, vroom, 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 right? So with cardiac conduction, what we've got is we've got an SA node, which is the pacemaker of the heart. Remember that, the SA node. The SA node can beat at about 60 to 100 beats a minute. So that's vroom, lub, dub, vroom, lub, dub. Okay? If for some reason the SA node fails, you got your AV node, which is kind of in the middle, atrioventricular, AV. That can take over if there's a problem with that one. But the AV node, if it takes over, it's going to be able to beat about 40 to 60 beats a minute. It's enough to keep you alive. It's slow, but it's enough to keep you alive. It's enough to give you perfusion or enough blood flow so that you don't die. And then we've got the bundle of His and Purkinje fibers down here, which is the final part of the electrical system. If the SA node and the AV node both fail, the bundle of His can kick in, but that's only going to make your heart beat 20 to 40 beats per minute. So 60 to 100, 40 to 60, 20 to 40. 20 to 40 beats a minute's not a lot of beats a minute. You're probably going to pass out. You're probably going to be dizzy. 40, 20, okay, that's very slow. A normal heart rate is 60 to 100 beats per minute, okay? All right. When we look at an EKG or an ECG, which means the same thing, and actually I want to write that here so that you know. So if we hear the term ECG or EKG, means the same thing. It's an electrocardiogram, and it's looking at the electrical activity of the heart. You know, they put the leads on your chest with the wires to the machine, and it prints out a paper. That's an EKG. When we look at it, there are some components of an EKG that must be there to say that your heart has a normal cardiac cycle. This is one lub-dub. 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 Right? So this is the P wave, and that's the atria. QRS is the ventricles. T is everything goes, fills up and does it again. So lub-dub, rest, fill. Lub-dub, rest, fill. Okay? So that is a cardiac cycle. Just know that. Know that in order for it to be complete cardiac cycle, there's a P wave, QRS, and a T. P, QRS, T. Got to be there. Okay? If something's missing, something's wrong. Okay. This affects your heart rate. Why does your heart beat the number of beats that it beats? Well, it depends. You have a cardiac center in your brain. It's right at the center of your brain, the medulla oblongata, right? And we've talked about the brain before. That's the cardiac center. And it either has an acceleratory side or an inhibitory side, okay? So what does that mean? The acceleratory side is what makes your heart rate increase. What are the things that can make your heart rate increase? Well, there are different things that can make your heart rate increase. If you exercise, if you are running around, if you are moving around, exercise will increase your heart rate. Why? Because you need more oxygen to your muscles so that you can exercise or run or whatever you're doing. So it kicks in. So the acceleratory center sends impulses to your sympathetic nervous system, which sends an impulse to your heart, particularly the SA node, with epinephrine or norepinephrine, which is a chemical giddy up, and your heart beats faster, right? Then on the other side of it, we have the inhibitory center. So what would make your heart rate slow down? Well, your blood pressure goes up. That stimulates that inhibitory center in the brain to get the parasympathetic nervous system to kind of secrete acetylcholine, the chemical neurotransmitter, to the SA node and the AV node and say, slow down, too fast, go slow down. This system is going on all the time. Your body is always monitoring your heart rate to try to keep you in homeostasis. That is the goal. Homeostasis, right? That's the goal. And all of these systems work together all the time to keep your heart beating at the rate that it should be beating. Now, things can go wrong When we get to med surg, we'll talk about the different things that can go wrong. Because just like your car, different parts of your car can break, wear out, same with your body, right? Only makes sense. Okay. The left ventricle contains the thickest layer of muscles in the heart. Is that true or false? Remember, the left ventricle is the queen mother. If you said true, you'd be right, because that's the one that's got to pump the oxygenated blood all through your body. So that one needs oomph behind it. It needs oomph behind it. Okay? It's got to have oomph behind it. All right, next. So this is just another explanation of blood flow through the heart. You can read this if you want, so that you can go through the steps, but the steps were up earlier and in the PowerPoint, and they might, whatever's easier for you, whatever works for you so that you understand the blood flow through the heart and body. Let's talk about some other things. Talk about collateral circulation. Collateral circulation is amazing, and it is the body's ability to do its own bypass when there's an obstruction. So if on your coronary arteries, over time, you eat badly and you have high cholesterol, hyperlipidemia, over time, plaque is building up inside the arteries of those coronary arteries, inside the walls of the coronary arteries, and slowing down the blood flow. And it can get to a point where it blocks the blood flow. Well, it happens insidiously, slowly over time. Your body will build up little teeny tiny arteries to go around where that blockage or partial blockage is, so that that part of the heart muscle keeps getting oxygenated blood. Amazing. Amazing. That's why the older man with the heart attack versus the younger man with the heart attack, if you have two patients, one man's 45, one man's 70, who's got a better shot if they have, like the left anterior descending, if a blockage is there? The older guy has a better shot because he's probably got collateral circulation built up. So that part of the heart muscle is probably not completely dead. The young guy hasn't had time for that stuff to build up. So, might not be good. Ischemia. Ischemia is the term for sometimes reversible injury to the cells from them not getting blood and oxygen. Okay, that's called ischemia. CAD is coronary artery disease. You need to know that. That's damage to the coronary arteries that can cause ischemia, or it can cause an MI, which is a heart attack. MI, myocardial infarction. Okay, so what is a myocardial infarction? Myocardial infarction is when there's an artery that's blocked, or more than one artery, coronary artery that's blocked, and there's no blood flow getting to that part of the myocardium, the heart muscle, the tissue dies. If the tissue dies, the heart can't beat. If the heart's not beating, that's a heart attack or an MI. And then the word angina. Angina is just the word for chest pain that's caused by a lack of blood supply to the heart muscle, like when there's a blockage. Okay, so these are all kind of related on this page. Okay. Let's see what is next. Next we have, I'm not going to get into coronary veins, but wherever there are arteries feeding oxygenated blood, there have to be veins to remove carbon, right? So let's look at the arteries. This is the arterial system in the body. So remember, arteries, away. Arteries carry blood with oxygen away from the heart and to your body. Okay. Your aorta is the biggest one. You have your ascending aorta, goes up, and descending aorta, which goes down. And then that branches out to all the other arteries and little tiny arterioles that are all through your body. Okay. Which you need to understand. You also need to know your pulse points, because when you take someone's pulse, what you're feeling is the heart pumping, the blood through the artery. So what are pulse points? Temporal artery, you have your carotid, you have your brachial, your radial, femoral, which is right in the groin, inguinal area, popliteal's behind the knee, posterior tib is kind of behind the ankle, dorsalis pedis, or called the pedal pulse, is on the top of the foot. Do yourselves a favor and find your own pulses on your body so that you can be more comfortable finding them on your patients. Okay. Then you have your veins. Here's your venous system. All of your veins start with little tiny, there's capillary beds that go to little tiny venules, that go to veins, that go to the biggest vein, the superior and inferior vena cava. Okay. So the superior inferior vena cava, biggest vein in the body leading to the right side of the heart, carrying deoxygenated blood to the right side of the heart. Okay. And one thing that you need to understand about veins don't have a pumping system, right? Your heart is the pump. It pumps the oxygenated blood through the arteries, all the way to the tips of your fingers, your brain, and to the tips of your toes. When the blood without oxygen, with carbon, goes into your veins, go back up to your heart, there is no pump. So how does venous return happen? I'm glad you asked. That's a very good question. Your veins have valves in them. Again, every so often, to every one of your veins are these little one-way valves. Again, one way, just like South Philadelphia. Blood's going one way. So when you walk, when you breathe, when you move, muscles contract and relax, and they squeeze the blood through the valve and up, through the valve and up, right? These one-way valves that are strategically placed all through our veins. If there's a valve that's damaged, which can happen, right? We know anything can happen. The valve gets damaged and lets blood go backward, flow backward. That's bad. That can be varicose veins, right? And everybody has seen varicose veins. That also can be venous stasis. Stasis means not moving. So that can cause the blood, the deoxygenated blood, to become trapped, usually down at the feet or lower legs. So remember that. Okay. All right. Next, capillaries. The capillaries are the teeniest, microscopic blood vessels that are found like in your nail beds. Okay. And they're found everywhere, but easy to find in the beds of your nails. Most of your blood vessels are capillaries. That's where they end. And they are the in between that connects the arteries to the veins. Okay. That's where oxygen and carbon exchange happens and nutrients and waste products happen. Okay. When we're assessing patients, one of the biggest things that we do is we check the capillary bed refill by pushing on the nail, letting go. When you push, it turns white. When you let go, it pinks up. How long did that take? 1 second, 2 seconds, 3 seconds? The quicker that it pinks up, the healthier or the better circulation the patient has. So you're looking for 3 seconds or less for that pink to return. 1, 2. Look how quick, right? Okay. There are layers of blood vessels, whether you're talking veins or arteries, they all have 3 layers. The tunica adventitia, the tunica media, middle, and the tunica intima, the inner layer. You don't need to know what they're made of. No one's going to ask you about that, but you should know that blood vessels have 3 layers, arteries and veins. The artery walls are a little thicker and stronger. Why? Because they're under pressure, because the heart, boom, boom, right? The heart's pumping blood through the arteries. Okay. Do pulmonary veins carry deoxygenated blood? That is false. The only time a vein carries blood with oxygen is at the heart. Okay. The veins and arteries of the heart are backwards. Okay. The veins carry oxygenated blood from the heart or to the heart, and the arteries carry deoxygenated blood from the right side of the heart to the lungs. So that's the only time it's backwards. Typically, arteries away, blood with oxygen, veins to blood without oxygen, but not at the heart. It's the opposite. Okay. The cardiac conduction system we already looked at, so let me move on. And this kind of explains the conduction system, the SA node, the AV node, right? And all that good stuff. So there it is again. And the pacemaker cells of the heart have 3 qualities that other cells in the body, other nerve cells don't have. They have automaticity, conductivity, and contractility. That's what makes your heart go do-do-do, do-do-do, lub-dub, lub-dub. Okay. We already talked about the EKG and the characteristics that have to be present, the P, the QRS, and the T. Okay. We already talked about the cardiac cycle, systole and diastole. There are two words that you need to know. They are at the front of this PowerPoint, but also they are here. So let's talk about it. When we check someone's blood pressure, we say it's 100/68. So systole is the contractions of the atria and the ventricles. Loved up. Diastole is when the atria relax and fill up. That's after the dub, right? So that is one cardiac cycle, right? Because the chambers fill up again, pump, fill up again, pump. Systole, diastole. Okay. When you listen to a heart, that sound, that lub dub, and that's actually what medical people call it, lub dub. S1 is the first sound. That's the lub part, and that's the AV valves when the ventricles contract, and that's loud, lub dub. The S2 is the second normal heart sound. That's the dub, and that's when these other valves close, relax. Now, there can be abnormal sounds. You can have an S3, which they call a gallop or a ventricular gallop or an early diastolic gallop or a proto-diastolic gallop. Tons of words for the same thing. S3 is a low-pitched extra heart sound, which you hear after the dub. So if you hear lub dub, not whoosh like a murmur, lub dub, that's a gallop. You can normally hear that in someone later in pregnancy for various reasons that I'll get into in the med surg part. And older folks sometimes will have an S3. It can be normal for them, but it's typically, sometimes it has to do with heart failure and other disorders. So it's not a normal heart sound. S4 is another extra or abnormal heart sound that you can hear. It's a low pitched sound that you would hear before the lub dub. The lub dub, lub dub. Okay. We talked about the gallops and the different rubs, murmurs, that kind of thing. There are lots of sounds that you can hear that are not considered normal. Okay. We're not going to get into all of them now, right? Just know there's an S1 and S2 that's normal. That's lub dub. S3 and S4 is either after the lub dub or before the lub dub, not normal. Okay. That's good enough for me. I'm not going to get into grave detail about cardiac output, but cardiac output is how much blood the ventricles can pump out to your body, oxygenated blood, how much they can pump out in 1 minute. Stroke volume is the volume of blood that's ejected with the heartbeat, right? So if you have low cardiac output, that means you're not getting enough oxygenated blood flow to your body, your brain. That's a problem. They were talking about left-sided heart failure, possibly different disorders. Okay. And there are different reasons for cardiac output to be affected. We're not going to get into Starling's law right now. You don't need to know that. But the sympathetic nervous system, the parasympathetic nervous system, all different reasons and different factors that can affect cardiac output. But we'll get to them when we get to med surg. Blood pressure. We're almost done. I know your heads are ready to explode. It's going to be all right. Blood pressure. Blood pressure is the force of the blood that's exerted against the walls of the arteries. Okay. And I'm going to actually change this from blood vessels to arteries because that is where blood pressure is measured. Okay. And we state it in millimeters of mercury. So if I say the patient is, patient's blood pressure is 110/68 millimeters of mercury, that's the measurement that you see on the sphygmomanometer, which is that blood pressure cuff that we use, okay? So, and you have a systolic, which is your top number, and you have a diastolic, which is your bottom number. And, it's recorded as a fractional figure. In other words, a number over another number. And here's a fun fact. If you subtract the diastolic from the systolic, you get a pulse pressure. That sometimes matters in, when we're talking about the ER or ICU or that type of thing. But just so you know, pulse pressure is the difference between the systolic and the diastolic, right? So in other words, subtract the diastolic from the systolic, whatever's left, that's your pulse pressure. Your blood pressure is regulated again, the medulla oblongata at the brainstem, right? There are lots of factors that affect blood pressure. The kidneys manage your blood pressure by managing fluid volume. If you have too much fluid volume in your body, your blood pressure goes up because you're increasing peripheral vascular resistance. In other words, it's harder for your heart to pump blood against big swollen legs with fluid in them, right? So blood pressure would go up. Age, if the smooth muscles in the arterial walls get a little stiff, right? Arteriosclerosis, that happens with age, not with me, with other people. That's going to raise your blood pressure. Plaque inside the walls that make an artery, instead of being this big, now it's this big because of the plaque, right? Lots of different reasons blood pressure, numbers can go up and down. But blood pressure is not static. Blood pressure is fluid. In other words, it changes when you move, when you sleep, when you get up, when you sit down, but small changes. There shouldn't be major dips or increases in BP. That would indicate something might be amiss, okay? And there are baroreceptors throughout your body that also help to manage your blood pressure. And other factors are your diet, physical activity, your emotional state, smoking, and of course, your genes, your genetics, which you can't do much about, okay? As always, we end with the effects of aging. Blood vessels can get stiff. Cholesterol can be high, which deposits in your arteries. That's atherosclerotic plaque. Blood vessels can be dilated because of damage to the muscles around them. Heart valves can not work right. They can start to get sticky or leaky. There can be occlusions in your arteries, coronary artery occlusions. Fibrosis can happen in the conduction system, which can make your rhythm of your heart go a little bonkers. The myocardium can get enlarged. You don't want that muscle big. You want every other muscle in your body big and strong, but not your heart muscle. You don't want that to get too big because then it's bad. Okay. It doesn't pump the way it's supposed to. Cells can't really absorb oxygen the way they used to. If you have, again, stress will kill you. Lifestyle and habits like diet, smoking, everybody else, not me, obesity, stress, right? All of those things have a profound effect on your heart rate and your function of your body, homeostasis, your blood pressure, everything. You got to manage your stress. You got to get a little exercise and you got to eat right. Okay. Everybody. It's a fact. Okay. The nurse notes a client's blood pressure is 130/98. What will the nurse document as the pulse pressure? I hope everybody remembers. 98, take away from 130. The difference is 32. There's your pulse pressure. Okay. Believe it or not, that's the end of this very lengthy lecture on cardiovascular. It's going to get fun, I promise you. The heart and the whole body's amazing. I keep telling you guys that, and I mean it. So we're going to be moving on to something else, probably respiratory, but as soon as we get this cardiac stuff down. All right, guys, have a great day, and I will see you later, alligators, and we're done. Bye.